Good morning, everybody, and welcome to this Facebook Live brought to you by the Lymphoma Research Foundation. My name is Joe Messeri, and I'll be your host today as we discuss different biomarkers and types of testing in lymphoma and what they indicate. And to help us break this down today, we are very lucky to have a special guest, Dr. Girish Venkat Raman, an associate professor of pathology at the University of Chicago. Doctor, thanks so much for joining us today.
Hey, Joe. Thanks for inviting me over.
We have a lot to cover here, so I want to jump right into it. What is the first step in diagnosing lymphoma?
Yeah, so just to give a background, one of the first steps would be the short answer is you need a biopsy that confirms that it's indeed lymphoma. So one of the first steps would be that a surgeon probably doing a biopsy and confirming the diagnosis of lymphoma. And there are multiple ways in which you could confirm this lymphoma. We will get to some of those details in a bit. But usually, with lymphoma, patients are see their primary care physician typically because they either feel sick or they have a swelling somewhere, and then they end up meeting their primary care physician. And in the usual course, the primary care physician would probably run some lab tests, blood tests, if you will, and if need be, and the patient is very sick and has a swelling in the neck or anything that relates to lymphoma, they might send or refer the patient to a surgeon, and usually the surgeon takes it from there, and then the biopsy happens, and typically there are multiple ways a biopsy could be done, and we will probably discuss all of that. But in short, that's it. You need a biopsy diagnosis that confirms lymphoma.
Why is that important? What is the role of a biopsy in the diagnosis, and do you always need a biopsy?
That's a very good question. It's actually a tricky one because there are some lymphomas that can be diagnosed from a blood test. So to give you a background, let me tell you a couple of things about the blood itself. So to give you a 101 on the cells that circulate in the blood, you have red cells that carry your oxygen, and you have your white cells that fight infections and are responsible for your immunity. We will not talk about the red cells or the third component, which is the platelets. The platelets are small cells that help your blood clot. So the cells that carry oxygen and blood clot are not really relevant for us at this time. Let's focus on the cells that are part of the immune system. And when we talk of those cells dealing with your immune system, those cells are called white cells. And white cells, again, are divided into cells called neutrophils or lymphocytes. There are some other white cell subsets that we won't talk about, but from a practical perspective, you have cells that fight immediate infection, and those are your neutrophils. And those that are educated to recognize foreign antigens and then fight slowly with memory, and those ones are your lymphocytes. And typically, lymphoma as we know it is a cancer of these lymphocytes. And when lymphoma happens, you can have cells, the lymphoma cells, that can come about in the blood. So lymphoma doesn't have to be really inside lymph nodes, and lymph nodes are often found in the neck, in the groin region, and areas like these. And lymph nodes are sometimes deep too. But there is nothing to say that lymphoma cells cannot come out in the blood. And so if a patient gets a blood test, which is basically blood counts to see how many red cells are there, how many platelets are there, and how many white cells are there, and how many kinds of white cells are there, you can easily decipher from these numbers in the peripheral blood that your lymphocytes are increased. And you could easily run tests on the peripheral blood and confirm some of the diagnosis. But again, this is only like 5% of lymphomas present in this easy manner where you just do a blood test and confirm the diagnosis. But the other 95% of lymphoma, usually doesn't come out in the blood. They stay inside lymph nodes, which are deep inside your tissues that take care of your immune system. And the only way you can get to a diagnosis is by getting a piece of that tissue that might have lymphoma and looking at it under the microscope and running a bunch of tests, and finally making a call of lymphoma on a tissue biopsy. So that's why. So you need a biopsy for the most part. Rarely you don't need a biopsy, and you can make that call. So that's where we are at. So that's where the role of the biopsy really comes in.
I think
Yeah.
Go ahead. I'm sorry. I didn't mean to cut you off.
No, go ahead. I was done anyway.
I think that might sound a little intimidating for somebody who's newly diagnosed with lymphoma. So how do you go about obtaining the biopsy tissue for the diagnosis?
Okay, so typically when we talk of lymphoma, the typical situation for most patients is they go to their primary care, like I said, and the primary care physician usually runs blood tests, and if they don't see anything in the blood tests, and the patient tells them, "Hey doc, I have like a 20-pound weight loss, and I never did any running in the past 6 months, and yet I've lost weight," which is sometimes not a good thing when you just lose weight like that without any effort. So when that happens, the primary care physician will examine the patient, or maybe they might do a CT scan, and if they find swellings in the patient, like say, for example, the patient has a swelling in the neck, and then they say, "I have a 20-pound weight loss," then the chances that the swelling in the neck is cancerous is pretty high when that happens. And you need to confirm what cancer is in that lymph node, if there is cancer, and if there is cancer, what cancer is it? So he refers the patient to ENT doc, and again, this could be in private practice, or the patient could be in a hospital-based setting, like patient might come to our ENT surgeon out in our hospital, and the ENT surgeon will see the patient, and they are not all about ordering more blood tests. Their primary goal is to look at that swelling and get a biopsy of that swelling and send it to pathology. Now, the ENT surgeon doesn't know ahead of time that this swelling has to be lymphoma, because they are not lymphoma oncologists. Their mind doesn't think that way. They will first think that maybe this is a cancer, maybe in the mouth or somewhere in the head and neck. That's not lymphoma, and maybe it's cancer that's spread to the lymph node. So that's a big if there when it comes to swellings that ENT surgeons will operate on. And so he will take a piece of it, send it down first to pathology, where we do an initial assessment to decide if this tissue is going to be lymphoma or not. So we do what's called an immediate assessment, or a lymphoma workup, and then we will decide. There are times when we have found out that the swelling is really not lymphoma, but it's actually a spread of some other cancer altogether, in which case we don't go chasing lymphoma after that time point. There are other pathologists that deal with non-lymphoma type diagnosis, and those are anatomic pathologists, and they will usually take care of things from there. So tissue biopsy is one way. So the surgeon might remove the entire lymph node sometimes, or the ENT surgeon might say that, "No, I cannot possibly go and remove the entire lymph node for you, because the lymph node is touching a major blood vessel. And if they go try removing the entire lymph node, they risk injuring that blood vessel right next to the lymph node. Because of those kinds of risks, they might just do a small needle core biopsy, where they go in with a needle and they just take out small cores of lymphoid tissue, small slivers, and not the entire tissue. So you can have a core biopsy like that, or you might have a complete lymph node or mass excision that happens. And rarely, more often than not, you will not have swellings that are obvious in the neck or the groin. You will have to do imaging, and in the imaging, you might see a mass inside the chest. In that case, the ENT surgeon will not take care of things, but the patient might be referred to a radiologist who is trained to use radiologic techniques and go and procure a biopsy from the deep sites, like be it inside your belly, be it inside your chest. They will insert a needle, maybe from the bottom of the neck, and then they'll go in with a needle, and they will have the patient under an imaging, like a CT scan or a machine of sorts that does imaging, and they will know exactly where the needle is traveling, and they get a biopsy of the mass. So those are called interventional biopsies. So in summary, you could either get the blood and make a smear of the blood and get to a diagnosis of lymphoma, in which case you get lucky. The second or more common way is a swelling in the neck or groin, where you can get an incisional biopsy or a core biopsy if it's going to be hard. And in deep sites inside the chest, or even the brain for that matter, those are all done under imaging guidance. You can't just stick a needle straight inside the head and try to get a biopsy, right? So that's not right. You need to be careful where the needle is going through, and track where your needle is going before you go get a biopsy. So those are interventional biopsies.
So with all of those options, what should a patient be asking their doctor before they receive a biopsy?
Yeah, okay, that's a wonderful question. So one of the first questions to ask is, do you really need a biopsy? How much can you learn from just doing blood counts and learning from the blood? So because I believe that the blood and the blood counts are indeed a window to what's going on inside. And especially with some lymphomas that will extensively involve the bone marrow, where all blood is formed, when that happens, your blood counts drop. And when you find a patient whose blood counts are really low, it's very likely that there could be a lymphoma that has totally gone and replaced your bone marrow entirely. So all your normal stuff has been replaced by lymphoma, and therefore normal stuff cannot be made, and therefore your blood counts might drop. In that case, you might be better off doing a bone marrow biopsy, which is done from your low back, and that actually is a better form of biopsy and less risky than going for this deep interventional biopsies, where they stick a needle inside your chest and brain and stuff like that. So those are much less risky. So certainly, I think patients should ask, can you do blood counts and double check what the blood cells are showing, and if lymphoma cells are in there, and then they can reevaluate if a referral to an ENT surgeon or interventional radiologist is required. So of course, the primary care physicians are not primarily lymphoma docs, so they don't really know ahead of time if a patient is going to have lymphoma or not. And there are certain lymphoma specific lab studies that are done in addition to lymphoma specific radiology, like PET scan and certain CT scan, that are relevant, which only lymphoma oncologists are aware of. And hopefully, if the patient ends up going to the lymphoma oncologist at the end of the day, then they might order those tests specifically, and we can discuss those later. Yeah.
Well, let's talk a little bit about it. What are some of the tools that are used by pathologists in lymphoma diagnosis?
Okay, so that's a good question. It's not something that's talked about much, but the tools at the disposal are still like 4 tools that we typically use. Yeah. So, like I said, the ENT surgeon sends the tissue across to the pathology receiving. That's what happens. He or they send fresh tissue to the pathology gross room. And in the gross room, we typically take the tissue and touch the tissue on a slide, and we stain that slide, a dry preparation of the lymph node tissue, and we stain it with one of our stains. And within 10 minutes, we can even say if this is going to be lymphoma or not. We make the determination. So that's called immediate assessment. That's one tool that we do. And then once we decide that this is indeed lymphoma, we make the decision to decide 3 different things. One is we portion like 60-70% of the tissue for the morphologic component, where we take the tissue and we embed the tissue in a paraffin block, we cut sections and make slides, and we look at it. So 60-70% of the tissue is used for that. That's the primary diagnosis method that we use, which is looking at it under the microscope. And about 10 to 15% of the rest of the tissue we will portion for flow cytometry. And flow cytometry is a technique where we isolate single cells from this piece of lymph node tissue, and we run it in a machine that tells you what biomarkers or antigens are there on the surface of the cells. And if there are certain kinds of antigens, it'll inform us as to what kind of cells these are within the lymphocyte subsets. So within lymphocytes, you have B cells, you have T cells, and if these are malignancies of B or T, then therapy is all very different. So we do have the burden of phenotyping whether these lymphocytes are B lineage or T lineage, and if they are malignant or not. So we need flow cytometry. And the other component is where we take the tissue and grow it in culture, and we look at the chromosomes inside the lymphoma cells, if it's lymphoma, that is. And when we look at the chromosomes, we can see a pattern of breaks in chromosomes or fusions of chromosomes that inform us of certain lymphoma diagnosis. For example, there's a very aggressive lymphoma in kids called Burkitt lymphoma, and where you have a fusion of two genes on chromosomes 8 and 14. And when that fusion happens, it drives the lymphoma. And this fusion is something you can see on the chromosomes. So that's called cytogenetics. Okay, cyto is cell, genetics is you're looking at the chromosome component of the cells. So we have morphology, we have flow cytometry, we have cytogenetics, and then we have the fourth and less frequently used genomic component that we will discuss down the line as we go down.
Can you talk about a little bit of the details in the testing? Now, you mentioned the flow cytometry, but what are these tests looking for when it comes to, we hear names like FISH or IHC?
Yeah. So yes. So when it comes to morphology, and you mentioned this word IHC, which is basically an acronym that we pathologists use for immunohistochemistry. So immuno is an immuno antigen. Yeah. Histo is the process of histology, where we cut sections and put them on slides. And chemistry is where there's a chemical reaction developed to detect these antigens on cells present on slides. So that's basically static flow. So immunohistochemistry and flow cytometry both pretty much give us the same information. In flow cytometry, you are just taking individual cell suspensions and looking for antigens on the surface. Whereas in immunohistochemistry, you might look for the same antigens, but when you look at things under the slide, you know how to look for architecture, because some lymphomas have a nodular architecture under the microscope, some look diffuse, some where the cells are small, some where the cells are large. And there are situations where lymphoma cells will partially involve a lymph node. In that case, you're better off using immunohistochemistry, where you can look at the involved areas and uninvolved areas separately using immunohistochemistry-based testing. And flow cytometry is not going to give you this information as accurately. And then the sample that you have for flow might not entirely capture the proportions of normal and abnormal that you might see on the slide. So there is some redundancy in what immunohistochemistry does and flow cytometry does, but I think we do like that redundancy in making sure that the diagnosis is right. So of course, the cytogenetics and the chromosomes give you a totally different picture, where you're looking at the DNA, not the protein. And Cytogenetics gives broad overlap of genes where they fuse, and it tells you about they use probes for large parts of the genes, and they will give you specific information about gene fusions and things like that. But one thing cytogenetics won't do is give you details on mutations in genes. So mutations is a much higher level of detail that you're looking for in the gene as compared to cytogenetics. Even though cytogenetics is a form of genomic testing because you're looking at DNA chunks, it's not the same as next generation sequencing, which is the next level of genomic testing that we use. And of course, after all these tools, we might still not be able to make a perfect diagnosis. And so, if we can't make a perfect diagnosis, we will voice our hesitation and tell what the issues are and discuss it with the maybe the ENT surgeon or even the lymphoma oncologist for that matter. So we need to convey our hesitancy about certain things or concerns before they get started treated as lymphoma or any specific type of lymphoma for that matter. Yeah. So that's where we are at, and sometimes we will ask for a second pathology review of the diagnosis that we ourselves make when we are unsure, and we will include that in our reports too, as it's one more tool that we use, and I think we should use it more frequently, especially when it comes to lymphoma.
So I just want to confirm and review here for a second. So cytogenetics are a type of genomic testing. That's correct?
Yes, yeah.
Okay.
Cytogenetics is a kind of genomic testing where you're looking at large portions of the gene. Yeah, and the probes that you have are for large segments of the gene. They are not really testing really small segments and point mutations. But yes, so that's why cytogenetics is a kind of mid-level detail of genomic testing, and just falls short of the proper next generation sequencing, where you actually sequence the whole gene and try to look for mutations within the gene. But it's a very valuable test in that you look at the chromosomes, it gives you a global overview of all the chromosomes in those cells. And next generation sequencing will never do that for you. And hence, a broad overview is probably needed first before we go on to these extensive high resolution testing that next generation sequencing based genomic testing offers. So yes, they are slightly different, and yet in some ways they are same.
So in your opinion then, is genomic testing or the term the same as the term biomarkers? And if so, how are they the same or how are they different?
Yeah. So, biomarker is a very broad word that we use. Yeah. Like, for example, let's say the patient has an indolent form of lymphoma that we call as follicular lymphoma. We typically will do a set of immunostains, CD20, CD10, and BCL2. These are three different markers that we do to get to the diagnosis of follicular lymphoma. And these are immunohistochemistry based antigens, and we test these using flow cytometry too. And we do have some redundancy in assessing the expression of CD20, CD10, and BCL2, either by immunohistochemistry or by flow. Technically, these are biomarkers. So these are biomarkers that inform us in telling that this is a B cell lymphoma, in as much as CD20 is positive. And when CD20 is positive, it tells you that any therapy that uses or targets CD20, yeah, we have antibodies against CD20 antigen on lymphoma cells, and the popular one that we know is rituximab, and it tells the lymphoma oncologist that rituximab will be useful and will work when the lymphoma is CD20 positive. So that's the first level of biomarkers that we use all the time. And now we have gone a little further than that with using CD10. And nowadays, usually follicular lymphoma expresses CD10. Now, there's a growing body of literature that tells you that there's a class of follicular lymphomas that can not have CD10 and yet be a follicular lymphoma. Um, and these tend to be high grade, these follicular lymphomas, and they often lack the genetic component of what follicular lymphomas usually carry, and that happens to be the translocation of the BCL2 gene on chromosome 18 all the way to chromosome 14, where you have a gene that's very active called the IGH gene. The IGH gene drives the BCL2 gene and prevents the lymphoma cells from dying. So that's what happens in follicular lymphoma. But these 14/18 negative follicular lymphomas sometimes don't express 10, and they are sometimes bad players. They might relapse sooner, or they might present in higher stage, and things like that. So to that end, the presence or absence of CD10 on these follicular lymphomas is also a useful biomarker. So pretty much all of these protein-based markers that we use as stains on slides are biomarkers. Now, these are all diagnostic biomarkers that have prognostic relevance. Now, let's move on to one more biomarker, which is called PD-L1, which is very popular these days as a prognostic biomarker because there's a lot of therapies being developed against this antigen. PD-L1 is what we call as a checkpoint inhibitor, yeah, and the basic idea or the premise of using PD-L1 is this. So like in Hodgkin lymphoma, the lymphoma cells will express this antigen called PD-L1, and PD-L1 will bind to its cognate ligand on the T cells, this antigen called PD-1, and through this interaction, it will stun the T cells that come to attack the lymphoma cells. And when that happens, the normal T cells in the patient cannot go and kill the lymphoma cells. And that's a major issue with the tumor microenvironment being totally suppressed by the lymphoma cell expressed antigen called PD-L1. So lymphomas that express high PD-L1 are better at subverting the host immune response against the tumor. So PD-L1 is a biomarker that has a huge prognostic relevance. And one more biomarker that we use is CD19, which is an antigen expressed on the lymphoma cells, and that tells you that these are B lineage lymphoma cells. And the presence of CD19 is quite predictive of the response to newer therapies these days called CAR T cell therapy that employ anti-CD19 based mechanisms. The logistics of how CAR T cell therapy works is beyond this discussion, but the expression of 19 is relevant prior to any CAR T cell based therapy. So CD19, CD20, PD-L1, CD10 are all a form of biomarkers. These are actually immunohistochemistry based markers. And we can also test for PD-L1 by FISH to look if there is amplification. FISH is basically fluorescent in situ hybridization, where we look at the genes and to see if the PD-L1 gene is amplified. And if the gene is amplified, there is going to be tons of protein made too. And if there's tons of protein being made, then that's going to protect the lymphoma cell. So there is a role for PD-L1 based FISH, there's a role for immunohistochemistry. And of course, flow cytometry is kind of a little redundant, but it does inform us about CD19, CD20, and CD10 for that matter. Yeah.
So all of these proteins that you're talking about, these are abnormalities that the genomic testing can identify. Is that accurate?
Yes. Genomic testing. Now, these are not abnormalities that we look via genomic testing. So these were primarily immunohistochemistry based or protein based testing that I'm talking of.
Okay.
When it comes to genomic testing, if you remember, I mentioned to you about sequencing the entire gene. Yeah. So there are certain genes that are recurrently abnormal or mutated in lymphoma. And the genomic testing, which goes to the higher resolution, looks at the DNA and looks at specific regions or genes that may be dysfunctional in lymphoma patients. And when they are mutated, then there are issues with the B cell signaling or T cell signaling in lymphoma cells. And I can probably tell you about some of these genomic markers that we typically use. One of these happens to be a gene called MyD88. So MyD88 is a gene that's responsible in B cell signaling. So what happens in a certain lymphoma called lymphoplasmacytic lymphoma is a mutation in this MyD88 where it constantly remains active in the B cell. And when that happens, the B cell is basically on steroids. It's continuously reacting to external stimuli and trying to send signals into the B cell and saying, "Hey, we need to be activated. There's something foreign." And so these cancerous B cells have a mutation in this MyD88 and are constantly active, and they're dividing and they're reacting. And when that happens, it tells you that this MyD88 pathway is overactive. And when the MyD88 pathway of B cell signaling is overactive, then you have a target to address this lymphoma using therapeutic targets that inhibit or decrease the MyD88 pathway of signaling. And one of those happens to be the BTK inhibitors, which is called ibrutinib. And there are several congeners of this drug which specifically target the MyD88 signaling, and they decrease the proliferation of lymphoma cells, and they give relief from lymphoma in this subset. So there is a rationale for this MyD88 testing in certain kind of lymphomas. So that's, I think, one of the paradigms for lymphoma genetic testing using NGS. Likewise, there are several other genes that are tested up front in certain lymphomas, like TP53, which is involved in DNA damage. And if there's a mutation in P53 gene, then it's bad for certain lymphomas as far as therapy goes. And two diseases where it's very relevant is chronic lymphocytic leukemia and mantle cell lymphoma, where typically TP53 testing, which is the gene for P53 gene, is critical before they even choose therapy for these patients. And likewise, there are several other genetic markers and mutations that are relevant, but we will not discuss some of these as of now.
So you mentioned the genomic markers and biomarkers. Should patients be requesting one of these from their doctors as they get their diagnosis?
Yeah, that's a tricky question. That the answer is actually yes and no. It depends on who you are talking to. So if the patient has a confirmed diagnosis of lymphoma, I think you can have a conversation with the lymphoma oncologist and ask them, how am I going to be treated? So when it comes to treatment, patients either go on a clinical trial that tests a novel agent, or a novel agent in combination with the standard therapy that we already know from all past patients that works to some extent. And usually, if the lymphoma oncologist finds that the patient is younger and fit, and he feels that the patient can go on a clinical trial of a novel agent that might have a potential benefit to give better response as compared to the standard of care. Like, for example, for diffuse large B-cell lymphoma, the standard of care is CHOP-R, which is a cocktail of chemotherapy drugs. But if the patient is young and the lymphoma oncologist chooses that the patient would be better off not just going for the standard CHOP-R regimen that we know works, but rather one more novel agent in combination with CHOP-R as a possibility as a clinical trial. And so when this choice comes, the patient can ask, do you really need specific biomarkers or genetic testing as part of this clinical trial enrollment? Or the patient can ask, are there any specific biomarkers that could be useful in predicting my response even if I'm treated using the standard therapy. Um, and again, some of these may be genomic testing, but I think the lymphoma oncologist primarily has to make sure that all the relevant immunohistochemistry biomarkers are there in place for him to decide therapy. So, so I think you can have that conversation with your oncologist, and and a lot of it depends on whether you get treated using the standard therapy or you get taken up for a clinical trial. Yeah.
So, in addition to the type of lymphoma that someone might have after being diagnosed here, what are some of the implications of these tests for both the patients and the doctors?
What are the implications? Yeah. So the implications are are a little different, depending on whether you are seeing the patients in the frontline setting, which is a terminology we use when the patient has never taken chemotherapy before and has a first time diagnosis of lymphoma, and they're going to go take therapy. So, like for example, I told you about CD10 as a biomarker in diffuse large B cell lymphoma. So when CD10 is positive, and and um, and we have to choose therapy, um, we can go an extra step to see if there is underlying genetic alterations in this 10 positive diffuse large B cell lymphoma. And one genetic alteration happens to be rearrangements of this gene called MYC, which is an oncogene, and and sometimes they co-occur with other alterations called BCL2, which I discussed in follicular lymphoma. So within the 10 positive subgroup, if you have alterations of this MYC gene and BCL2 gene, both of these alterations can be detected by FISH, or what I call a cytogenetics. Um, those patients especially have really bad outcomes if they get treated with CHOP-R, which is the standard therapy for diffuse large B cell lymphoma. And again, full disclaimer, I'm not an oncologist, but just a pathologist with basic knowledge of the therapeutic options. So when you see the diagnosis of diffuse large B cell lymphoma, it's imperative that you know if it's CD10 positive or not. And if it's 10 positive, are there alterations of MYC and BCL2 genes? And if there are MYC and BCL2 alterations, you are better off with a stronger form of chemotherapy upfront. And one of those options is EPOCH-R. And we have several trials going on for those patients who have both MYC and BCL2 alterations. And those are called double hit lymphomas. Those double hit MYC BCL2 lymphomas are enriched in the CD10 positive DLBCLs. So the testing does funnel from CD10 going to test for MYC BCL2, and that pretty much determines what therapy they get. So this is a huge implication, and I have seen several times where they've not done this extra testing, and patients have been treated as pure DLBCL with CHOP-R for what was thought to be just a DLBCL with 10, and then they come with relapsed lymphoma, and then things become harder when you have not looked at the testing fully upfront. So these are some of the things that could have implications. And of course, testing for MYD88 mutations, like I said, which is relevant in a disease called lymphoplasmacytic lymphoma, where patients could benefit from BTK inhibitors. And so, so there are some mutations that need to be tested in the frontline setting, like MYD88, MYC-BCL2, and DLBCLs. And as I said, there are several other situations in certain other lymphomas where it matters. And so these are certainly there are implications to these tests. But again, we don't do all these tests in all the lymphomas up front. Yeah.
And what, if any, type of genomic testing is coming down the pipeline right now that might be exciting for both pathologists and oncologists?
Yeah, from a pathology standpoint, there are some biomarkers that are coming for useful for diagnosis, where we already have certain markers against mutated proteins. I find that very exciting. One of the antigens against which we have an antibody is BRAF. BRAF is a gene which is sometimes mutated. There's a mutation in BRAF, and it turns on the BRAF pathway, and it activates the cells, and they go into overdrive mode. And recently, we have an antigen that we have a primary antibody by immunohistochemistry, where we can detect that mutated BRAF at the protein level. So it so happens that the mutated BRAF gene makes a protein which has the same signature as the gene, and we are able to look for that mutated gene using immunohistochemistry. And the advantage of immunohistochemistry is it's really fast. You get the answers in one day. Whereas with all the genomic testing, like sequencing and stuff, you're probably going to wait at least 3-4 days, maybe even 5 days, even a week, maybe 2 weeks if you're
Wow.
sending it out. So you are talking of a lead time right there. So the immunohistochemistry has that huge lead time over these genomic testing. So there are such newer IHC markers that I find very interesting and intriguing, and I use that routinely in my lab, especially for certain histiocytic disorders. And then of course the NGS itself, the technology is changing so much, and the prices are coming down day by day. So to give you a background, we don't routinely use NGS in the setting of lymphoma as frequently as we do in patients who have leukemia. So myeloid leukemias, which arise from the precursors of the neutrophils in the blood, those are diseases where genomic testing is routinely done at frontline. So every patient literally gets genomic testing at frontline, and there is a lot of data for that as to why it needs to be done. And there is insurance pre-authorization for pretty much most of myeloid leukemias upfront. But we don't have that same kind of lobbying in the setting of lymphoma, because not all lymphomas necessarily need genomic testing from a diagnostic perspective or from a prognostic perspective or therapeutic perspective for that matter. But with the prices coming, and a lot of it has to do with the pricing. So the genomic testing does drive up the costs, and hopefully insurance companies pay for it. But if insurance companies don't pay, then patients may get stuck with a huge bill. And we don't want to be in the sticky situation where it's a marginally useful test that we did and we rack up the costs. But with the price of NGS coming down day by day, I think we will use NGS more frequently from a pathology standpoint, and hopefully this data will be useful for patients down the line, in pretty much like every lymphoma patient, because therapy is getting more and more targeted, looking at genetic signature in lymphoma cells. And I really hope that day is going to come for lymphoma too. So NGS progress is one thing that's going to be more frequent down the line. And last but not the least, I will also touch upon cell-free DNA and mRNA. These are very new technologies that are in their stages of infancy as far as clinical use goes. These are tests that you can do on your blood. You draw a sample of blood, and the premise is the lymphoma cells sometimes secrete all these abnormal antigens and DNA, and they shed them into the blood from the lymphoma tissues. And it's the hope that we can detect these abnormal DNA from the tumor cells in the blood using just a blood test. You look at the plasma of these patients in the blood. So the plasma is the liquid component of the blood outside the red cells, in which all the red cells are floating. So you collect the plasma, and then you look at the cell-free DNA, and you look at the DNA, and you can decipher pretty reasonably that this belongs to a lymphoma, this DNA, based on the mutation profile of the DNA segments that you isolate. And hopefully that becomes a non-invasive way of getting to lymphoma and prognosticating. So there's a lot of clinical trials, not clinical trials necessarily, but a lot of studies, I would say, where we do have enough information that the cell-free DNA technology is actually good. It does help prognosticate. Our own group actually published some data earlier on this method retrospectively in diffuse large B-cell lymphomas. And our hope is we can get to a diagnosis of lymphoma in these patients without necessarily having to do a tissue biopsy in a certain subset of patients, especially when they're really sick. You don't want to go get a biopsy from a deep site and endanger the patient. And so hopefully these cell-free DNA technologies and this NGS technologies, where the costs are coming down, and the newer IHC markers that we are using will all help improve the outcomes and diagnosis for these patients with lymphoma.
Well, much like the rest of the field of lymphoma, it sounds like a very exciting and hopeful time as it comes to this testing here.
Yeah. Let's hope so. Yeah.
Well, Dr. Venkat Raman, thank you so much for your time today. We really appreciate it. Anyone out there, if you have any questions that you want to follow up on this, you can always head over to the lymphoma.org website for more information on diagnostic and genomic testing. And of course, you can always reach out to the LRF helpline. That number is 800-500-9976. For Dr. Venkat Raman, I'm Joe Messeri. Thank you so much for watching this Facebook Live, brought to you by the Lymphoma Research Foundation. Have a great day, everybody.